Welcome to Trying to Conceive with Dr. Sasha Hakman, where we break down the science of fertility, share real patient stories, and explore the latest innovations in reproductive medicine. My name is Dr. Sasha Hakman, and I'm a double board certified OBGYN and reproductive endocrinologist and infertility specialist. I practice at HRC Fertility in Beverly Hills, but this podcast is an independent project created and hosted by me separate from my clinical work. Don't forget to subscribe so you never miss an episode. And if you want exclusive updates and resources, be sure to sign up for my newsletter. Just click the link in the episode description. Welcome to Trying to Conceive with Dr. Sasha Hakman. Today's a solo episode where I'm going to be answering your questions. I tend to try and do weekly Q&As, and traditionally I would always answer them in my stories on Instagram, but sometimes I'm limited on how much I can explain in a quick story. Hopefully I can elaborate more on your questions here today. First question, chronic endometritis, was treated with antibiotics. Should I do an embryo transfer right away, or should I be waiting a couple months? Okay, so let's start with what chronic endometritis is. This is chronic inflammation present inside the lining of the uterus where implantation should take place. We know that if chronic endometritis exists, that this can significantly reduce the chance of implantation and a pregnancy after an embryo transfer. The way we actually test for this is we do a biopsy of the lining of the uterus. Before we do an embryo transfer, we test for specific cell markers that can indicate the presence of inflammation or endometritis. Some companies will do sensitivity tests to tell you which antibiotics are best to treat, but ultimately the treatment is antibiotics. The most common antibiotic prescribed for this is doxycycline. Once the course is complete, with the next cycle, you get ready for a transfer. If you're on birth control pills, you can stop that and get ready for a transfer right away. However, my school of thought is you tested positive for something, you were treated for antibiotics. Embryos are so precious, and depending on how many you have, especially if it was difficult to get these embryos either due to age, multiple IVF cycles, or using previously frozen eggs, these are embryos you can't get back. After you are treated for your chronic endometritis, it is best to do a test of cure. Rebiopsy the lining, retest, and ensure that inflammation has been resolved. Okay, next question. Reasons for low percentage of mature eggs after an egg retrieval. This is a good question. So there's a number of reasons why you may not have gotten a lot of mature eggs. Reason number one is if your ovarian stimulation protocol if you weren't pushed enough where the follicles were big enough to suggest a mature egg, you may have thought, okay, I have 20 follicles, so that means 20 eggs, right? It might be 20 eggs, but it might not be 20 mature eggs. Usually, I will not count mature eggs for follicles under 17 millimeters. It is possible to get mature eggs from follicles that are smaller, even smaller than 15, but that is not always common. Ideally, you want to aim for bigger follicles. I tell my patients anything smaller than that, do not count it before the egg retrieval. I try to set realistic expectations. It could be, depending on your situation, that an ultrasound technician told you the number which wasn't really accurate, or you were just given the total number of follicles, but not necessarily the number of eggs predicted to be mature. Another reason would be that you didn't receive a strong enough trigger. For some people, I have noticed if you do a Lupron-only trigger, you may get lower maturity compared to using HCG. The difference between Lupron and HCG is the risk of ovarian hyperstimulation syndrome. In some patients who have low egg reserve, I never worry about hyperstimulation syndrome, so I always give HCG trigger. The type of trigger may influence how many eggs are mature and the dose of the trigger as well. I always like to confirm that the trigger worked. We bring patients back in our office to confirm that the hormone levels of either LH or HCG, depending on which trigger you received, is elevated. That way we know it's in your system and it's doing its thing. Could also be that there wasn't enough time given from the trigger to the time of the egg retrieval for whatever reason. Either you took it at the wrong time or they have a shorter interval. Every individual is different. It could be that your normal is you require a little bit more time after trigger, 36 to 37 hours before the retrieval. Finally, it could also just be that some eggs are never going to resume meiosis. What is a mature egg? Mature egg is an egg that continues its cell division, and so it expels a copy of the chromosomes out, so it can now accept DNA from sperm. And that resumption of meiosis happens at the time of ovulation. And if meiosis does not resume, when you look under the microscope, it looks immature. So it doesn't even matter how much hormonal stimulation you provide, they just will not mature. Sometimes switching the protocol around helps to improve maturation, or pushing the follicles to a bigger size can improve maturation, but sometimes none of these strategies actually work. Oftentimes it's just gaining more information through several different ovarian stimulation cycles, which I know sucks, but that's usually where we find out more information. Okay, so next question, reasons for low percentage of eggs that fertilize on ICSI. ICSI is intracytoplasmic sperm injection, and I talk about this at length in the Basics of IVF episode. With ICSI, we're looking for the best looking sperm that have normal morphology, they're motile, so that means they're swimmers, and we immobilize them and inject them directly into the egg. And in theory, that should improve fertilization rates, but unless there's severe male factor infertility, or those eggs were previously frozen and then thawed, which makes the shell of the egg really hard to penetrate by sperm, then technically speaking, ICSI actually is not always really indicated. We mostly do it to avoid the situation of total fertilization failure, which can happen in 5 to 15% of IVF cycles. And that's the main reason why most clinics will implement this for all IVF cycles, but it doesn't always actually translate that way. The other thing to think about is maybe fertilization was low because there's an egg quality issue or sperm quality issue. There are a lot of reasons why fertilization is not as high as average, and the national average is about 70% of eggs being injected with sperm. Okay, so thoughts on day 7 PGT-normal embryos, transferring to after 2 failed day 6 PGT. What does all of this mean? Day 7 PGT, which stands for pre-implantation genetic testing, means testing the embryos for chromosomal abnormalities. So if they've been tested, we're selecting the ones that are chromosomally normal. And when we go to incubate embryos in the lab, we incubate up until day 7. Historically, we used to incubate up until day 5, sometimes day 6. As our technology has improved and our knowledge has improved, we now culture all the way to day 7 because some embryos are just slower to develop. Now, statistically speaking, day 5 embryos do the best. Day 6 comes pretty close, and day 7 has a much lower rate of implantation and pregnancy. It is less likely to work than your day 6 embryos, but I have had patients where we transfer the best embryos and they all fail, and the only ones that were left were 2 very low grade day 7 embryos that implanted. And in one most recent case for one of my patients, both implanted, leading to twins. So it can definitely happen. I would never discard a day 7 embryo that is tested normal. I would absolutely still use it, even if all the day 6 embryos did not work. You never know. Why might betas not rise appropriately, but pregnancy continues to grow well? So I think that there is a huge misconception of what is considered a normal rise for your HCG levels in early pregnancy. If you are monitoring HCG levels, as we often do after an IVF cycle, if you did an embryo transfer, most people think that betas should rise or by doubling every 2 days. But the reality is we want to see a 50% rise in beta every 48 hours. That's usually a really good place to be. I have seen cases where the rise can be as low as 20%, even lower than that, and still result in a viable pregnancy. So it's all about the clinical picture. If it continues to rise and then you get an ultrasound, baby looks good, and that fetus is growing from week to week, that's great. I would not even sweat it when it comes to the HCG levels. Okay. I'm 39 years old with 1 PGT-normal embryo, should I do a natural cycle FET or programmed FET? Great question. So a natural cycle FET is where we rely on your ovulation and the follicle that released the egg to produce all the hormones necessary to support early pregnancy, which essentially involves very little medications. A programmed FET is hormone replacement therapy where we give estrogen to thicken the lining of the uterus. And then once that lining is ready, we add on progesterone, usually progesterone in oil. So it's intramuscular injections in your butt every day until you're about 10 weeks pregnant. They're brutal. I did them. They sucked. Now, both have very comparable pregnancy rates. So there's ultimately no difference in success. However, what we do know about natural cycles is that they have a lower chance of pregnancy-related complications that we see with IVF pregnancies from programmed cycles. Gestational hypertension, which is high blood pressure in pregnancy, can be dangerous, as well as preeclampsia and other vascular and placental conditions that we tend to see with programmed cycles. So you are significantly reducing the risk of pregnancy complications, which is wonderful. Honestly, also physically speaking, it's just so much easier on the body compared to a programmed cycle. For me personally, if I had to choose, I would choose a natural cycle FET, especially if you cycle really predictably, you respond to medications predictably as well. But of course, it's not just a personal choice. It's also what your physician feels comfortable doing, what they're used to doing in their practices. And it's also not a bad idea to ask what the pregnancy rate differences are for natural cycles versus programmed, because every IVF lab should look at their internal data. Every place is a little bit nuanced, and they might be finding that they have better success with programmed FET, and you might find that you just want to maximize your success and you'll do anything for it. PCOS, 33 years old. Femara was successful in 2022 to lead to a pregnancy. I've been on birth control. How long to wait after stopping birth control to start Femara again when I'm ready to conceive? With birth control pills, you can stop immediately before wanting to start. So let's just say I'm ready to start now. I'm going to stop the birth control pill today and wait to have a period within a few days. And with that period, get started on taking Femara to induce ovulation. Femara is letrozole, which is what we call an aromatase inhibitor, is blocking the conversion of testosterone to estrogen. And so it reduces your circulating estrogen levels, making the brain perceive that, okay, there's not much estrogen in the system. I have to secrete follicle stimulating hormone to help recruit follicles in the ovaries. Sometimes it'll actually help recruit more than one follicle. So it's always important to get monitored with ultrasound if you are taking drugs like Femara so that you're not accidentally releasing 3 or 4 eggs and getting pregnant with triplets or more. So that has to be under physician supervision, but you can essentially get started right away. Can I keep going doing Orange Theory or HIIT training around the time of my transfer? So the answer to that is a little bit tricky because it depends on the doctor you ask. I'm a big advocate for continuing to exercise around your fertility treatments. Now, if you are someone with very low BMI and you're doing high intensity training, around the time of transfer, I would say tone it down. Let's do more low impact training rather than high intensity. If you've been doing this for a long time, have a good caloric intake, healthy BMI, then it's probably okay to do it. There's really limited data on exercise surrounding embryo transfers. I personally continued to work out around the time of my transfer. I even went back to the gym a day or two after my embryo transfer, lifting heavy weights. I modified a little bit just because I was kind of paranoid, like you did something really crazy that your body's going through. But if you really think about it, women are getting pregnant all the time on their own, doing crazy stuff. And if as human beings, we were so sensitive to exercise that we weren't able to procreate, we probably wouldn't survive as a species. So I usually tell my patients, if this is something you've been doing for a long time, it doesn't feel like overexertion, then go for it. You can always just modify. So listen to your body. 29 with low AMH at 0.5 from a Fragile X premutation. Is a DOR Lupron flare protocol for IVF the norm? Okay, so I love this protocol. We give Lupron. Initially, it tells the brain to secrete FSH and LH, the preformed storage of it. But after a few days of Lupron, it actually has the opposite effect where it will desensitize the hormone signaling of the brain to completely shut down. So first few days, it helps flare the increase in recruitment of follicles in the ovaries, and then it will shut down any communication after a few days between the brain and the ovary. This is very useful for getting that initial recruitment and then preventing premature ovulation in the ovaries so that you're not losing those eggs before egg retrieval. Now, that in combination with adding on FSH in injectable form tends to have a really good cycle outcome for diminished ovarian reserve. I do love this protocol personally. I used to use it a lot until we started using at HRC something called a long Clomid protocol, which we're undergoing a clinical trial for right now. This is where we give an oral pill of Clomid in combination with recombinant FSH. Those two medications help to prevent premature ovulation and improve the response to the ovaries. It works really well on the large majority of patients. I've maybe only had 1 or 2 patients who didn't respond well to it. They also turned out not to respond well to any protocol. So that's likely an ovarian issue. There are a couple of protocols and other strategies you can do for diminished ovarian reserve. Keep in mind that because you are 29, your age is also working in your favor. It's great that you are going to retrieve your eggs and preserve your fertility. I don't know your exact medical situation here, but I do love this protocol. I think it's a great protocol overall. How is IUI timed? So IUI is typically timed where at the moment of ovulation, let's say you have a dominant follicle that's ready and your lining looks good, your doctor may choose to give you a trigger shot to induce an LH surge. If you're getting a trigger shot, the IUI happens 36 hours later. But if you are naturally surging on your own and about to ovulate, the IUI will happen the next day. Okay, Clomid does increase follicle size or not. How long to wait for size for a trigger shot? Okay, so what Clomid does is it blocks the estrogen receptor in the brain. And so what the brain does as a consequence of that, because the brain thinks it's tricked into thinking you have very little estrogen in the body, it starts secreting more FSH. And so it helps to recruit a dominant follicle in the ovaries. And depending on the dose, it may recruit more than one dominant follicle. And the size that we're typically aiming for at the time of trigger is around 20 millimeters in size, give or take, depending on the whole clinical scenario and clinical picture. So what does your lining look like? What do your hormone levels look like? And from there, your doctor will decide when to trigger. But the most common scenario is if you have high estrogen levels with Clomid and you have at least a 20 millimeter follicle and your lining looks good, you will get triggered that night. Thoughts on testing the vaginal microbiome? Is it a waste of money? The vaginal microbiome testing is fairly new, but what I do love about companies like Evie, they do a lot of validation and clinical testing. A lot of their money is spent on proving scientific accuracy of their claims. I do think that it's a really interesting topic, something that has been overlooked for a very long time. And I love that there is more testing out there, given how we have barely moved the needle in acquiring information as to why treatment may not work or why someone may have unexplained infertility. Maybe it's helping to explain more. I'm very intrigued by this, and I don't think it's a waste of money. It's still very early on, but I think it could be really helpful information, especially if it comes back really abnormal. As we get more data, there will be more compelling evidence. The preliminary data is very intriguing. So I definitely wouldn't say no to that. Follicle size with Clomid, 100 milligrams for IUI success. I kind of went over that already. You know, usually we're aiming for 20 millimeter follicle. Okay, so a 5AA embryo came back with no DNA detected. Should we thaw and retest or not? This is a tricky one. I am not a fan of thawing, rebiopsying, refreezing, and then eventually rethawing again. I think you're just increasing the chance of damaging the embryo and reducing the odds that that embryo is actually going to work. I've actually done embryo transfers with embryos that had no DNA detected. Usually it's user error. It could be that the biopsy performed was not very good. It could be that those cells got lost when being placed in the tube that gets sent out. Once the facility that does the PGT testing received the sample, there just wasn't enough DNA. There are so many reasons where we just lose the DNA along the journey of getting the biopsy sample to the lab. To me, it's just like transferring an untested embryo, which is not necessarily a bad thing. Let the body decide. If you go to test and it comes back as euploid, absolutely transfer it, see what happens. But if you have to really make that decision of whether to rebiopsy, my vote is always don't do it. Just transfer the embryo, see what happens. Do you still proceed with the IVF cycle if there is a cyst? I try not to. Cysts can sometimes interfere with the success of a cycle. Sometimes I do, depending on the scenario, like if the cyst is really not resolving, or if it's really small, or if it's not hormonally active, it's not really doing anything, it's just there. Then in those circumstances, I just say, let's get started, let's get going, especially if there's scheduling conflicts for the patient. But if you have the ability to wait, and if the cyst is really large or hormonally active, I would say, just wait for that cyst to resolve before you get started on an IVF cycle. There's a lot on the line here. You don't want to waste it. I have a few children. I'm trying to get pregnant for close to a year. What do you suggest? Okay, so if you've been trying to get pregnant for close to a year, I would say definitely go get evaluated. Secondary infertility can happen at any point in time. I've seen it happen in women who already have 4 or 5 children, and they're perplexed as to why it's not happening. Don't forget, if you have multiple children, you've aged since then. And female age is a big contributor to decline in fertility. But also sperm quality may have changed. It's just a good idea to get an evaluation to see what is going on, so that potentially there is something treatable, or it could be unexplained, but it's good to get in, get the information, data gathering, and then know what your treatment options are. I saw you posted about this, confirming that I can exercise, run, do weights while egg freezing if I regularly do. So I shared my second IVF journey on Instagram. I showed that I was exercising throughout the entire ovarian stimulation cycle. I even went back to the gym the day after egg retrieval. Exercising made me feel so much better and reduced the bloating for me. I listened to my body. So if there was any positions that made my ovaries feel like they were jumbling around, I just modified that position. Overall, I was able to continue exercising just as rigorously and intensely. Talk to your doctor about it, but listen to your body. If you feel like you're up to it and it feels great, then I don't see why not. I'm 31 and my AMH is 7. What should I do? So if you are having regular menstrual cycles, then that's great. You just have really high ovarian reserve. If they're irregular and you think that there might be something else going on, like PCOS, get in with your OBGYN or with a reproductive endocrinologist to get evaluated to see what is going on and what to do to manage it based on your personal goals are and where you're at right now. Any risks, benefits to using castor oil pack and heat in preparation for FET? I'm just not a fan of castor oil. Just not a fan of it. Using heat in preparation, I mean, I guess that's fine if you want to use a heat pack over your pelvis, but none of these things have been proven to help in preparation for an embryo transfer. In fact, there's really little that you can do to manipulate the outcome of your transfer, aside from basic lifestyle things: nutrition, exercise, sleep, stress management. I talk a lot about this in Optimizing Your Natural Fertility. That episode is applicable to anyone who is just starting to try to conceive or is in the middle of fertility treatments. This is all I have time for questions today. We will resume a Q&A in a separate episode. Thanks for joining. And if you have any more questions that you want me to cover in following episodes, make sure that you comment in the description of this episode.